This is imaging of the lumbar intervertebral disc. I'm Pat Battaglia from Logan University. Before we get into the heart of the lecture, which is imaging anatomy, pathology of the lumbar intervertebral disc, I just wanted to throw out this disclaimer, just sort of get this out of the way, so to speak. We know there's a number of false positives with spine imaging in particular, but really all imaging has a lot of false positives associated with it. For example, 20% of those age 14 to 25 have degenerative discs on radiographs, and 20 to 75% under 50 have herniated discs on MRI, and you can see the remainder of the statistics here. So certainly false positives is a big problem. It leads to inappropriate aggressive interventions such as injections and surgery and excessive patient worry, and can really confound spinal treatment. So it's important we appreciate that as we spend the rest of the lecture today discussing lumbar disc pathology. While we can really see a lot of lumbar anatomy and appreciate some of the subtleties between disc bulges and herniations and high intensity zones, it's always important to context that appropriately. But I think we can agree that sometimes disc pathology has high clinical relevance, especially in our athletes with acute disc herniation, with nerve root involvement. So it's important to know the anatomy. It's important to be able to make sense of the imaging pathology, and it's important to be conversant in the up-to-date language that radiologists will use in their report so we can make sense of the word salad of an imaging report and best care for our patients. So while there's a high false positive rate at spine imaging, and while that's very important to keep in mind, sometimes the imaging finding is very important, and we have to know how to make sense of it and context it appropriately. To start our review, I want to review just some of the anatomy of the intervertebral disc. Here's a mid-sagittal T2 weighted image of the lumbar spine, showing us some of these salient anatomic features of the intervertebral disc. This bright piece of anatomy here is the central nucleus pulposus. The dark outer portion is the annulus fibrosus. And notice how I'll call it a healthy patient, asymptomatic patient set, the outer annulus does not extend too much into the spinal canal. Now, oftentimes, if you see extension of the annulus into the spinal canal, this is usually just indicative of age-appropriate disc bulging. It's very important we do not call, with few exceptions, disc herniations off of our sagittal images because they're misleading. Oftentimes, something that may look like a disc herniation is in fact just a disc bulge. Disc herniation do have some or a bit more clinical relevance than disc bulges seem to in the absence of clinical stenosis. So it's very important you appreciate that while this is normal in the sense that the annulus doesn't extend at all into the spinal canal, sometimes it will, and usually that's in the setting of disc bulges. We have to use our axial images to diagnose disc herniations. So here's axial image through the L4-5 level. You can appreciate the outer annulus fibrosis and the inner nucleus pulposus here. What I also want to say is as we scroll through the axial projection of the lumbar spine, in relation to disc pathology, we're oftentimes concerned with nerve root interface, whether it's disc material sort of contacting the nerve root and or frank compression of the nerve root. I want to remind you it's usually the surrounding inflammation by a disc herniation that causes neuritis and pain, whereas it's the compression of the nerve root that will cause focal deficits such as weakness and or sensory deficit, numbness, and tingling. So it's important we refresh a little bit of the somatotopic anatomy or organization of the cauda equina nerve roots. I'll remind you they're arranged front to back in an organized fashion. So for example, this will be the L3 nerve root here, then the L4 in the back, L5, etc. That's why you need a quite large disc herniation to compress the S2 through 4 nerve roots to produce the clinical syndrome of cauda equina syndrome, because those nerve roots are protected dependently in the back of the thecal sac. One of the more common pathologies, so to speak, that you'll see in the intervertebral disc will be a bright spot in the posterior annulus. So it's important we know the terminology surrounding this. This is most appropriately called an annular fissure, which is just separation of the outer fibers of the annulus with some fluid extension in between the two. Other terms you might hear for this are annular tear, which is a little bit harsh of a term to use, or high intensity zone, which is probably more appropriate. It's just a bright spot in the back of the disc. Earlier work suggested that this bright spot was associated more likely with quote-unquote discogenic type back pain. More recent investigations, however, question this. So we don't quite know the full significance of this annular fissure, but it's seen commonly, and radiologists will comment on it quite often in the report. So what is it? It's a little bright spot that you see here in the back of the annulus fibrosus. Here it is on the axial image. So when you see annular tear, annular fissure, or high intensity zone on your MR reports, this is what they're referring to. The clinical significance of this is highly debated. In addition to annular fissures, other common findings in intervertebral disc are disc bulging. Disc bulging is an age-appropriate event that is usually innocuous, but it will cause progressive spinal stenosis and predispose to acute radicular features in the right clinical context. So it's important we know a little bit about the terminology of disc bulging. Here's a normal disc, and in a normal setting, the outer margin of the disc, by definition, to be normal, should be within the bony confines. So in other words, there should be no disc material extending beyond the bony margins of the vertebral body. That's a technical normal feature if we're trying to operationally define what is a normal disc. In addition, the posterior aspect of the disc should be concave. So it should be a subtle little concavity to the posterior aspect of the intervertebral disc in a normal setting. The only exception is that L5S1, a normal disc there, does not have that same concavity. In the setting of diffuse bulging, the way it was taught to me in my residency was to conceptualize a beach ball that's sort of half inflated that someone sits on, whereas the disc margins just extend circumferentially beyond the confines of the vertebral body. This is diffuse or symmetric disc bulging. In asymmetric disc bulging, you get lopsided disc bulging. You see this quite often in your patients with a degenerative scoliosis. There'll be a high association between the two. Asymmetric disc bulging. In either diffuse or asymmetric disc bulging, the technical definition of a disc bulge is when you have disc tissue extending beyond the confines of the vertebral body more than 50%. So in other words, more than half of that vertebral body is now uncovered by disc material. That's the technical definition of a disc bulge. While often asymptomatic, it does predispose to spinal stenosis and other sequelae. More progressive and less frequently seen than disc bulges are disc herniations. Disc herniations have two main flavors: a disc protrusion, which is where the base of the extended disc material is wider than the length, or a disc extrusion that has a narrow base but is longer anterior posterior. Protrusion versus extrusion. Extrusions, in addition, can go on to progress to sequestration, where a fragment sort of breaks off and migrates in the spinal canal. Protrusion versus extrusion. This is somewhat arbitrary in the sense that both can cause radicular pain, both can cause radiculopathy. So it's somewhat of an arbitrary radiology or pathoanatomic distinction. But protrusion versus extrusion, that is the difference between the two, is the base relative to the width, front to back. Extrusions can go on further to form what are called sequestered disc fragments. When disc herniations are described in the imaging report, oftentimes one of these descriptors will be used. Disc herniations are typically described whether or not they're in the central zone, the subarticular zone, the foraminal zone, or the extraforaminal zone. In addition, terms such as central or paracentral will be used. So for example, I would say there's a left paracentral disc herniation, or there's a central disc herniation. But for standardization purposes, it's important to use these terms: central zone, subarticular zone, foraminal zone, and extraforaminal zone for localizing a disc herniation. Here's a case of disc protrusion from Radiopedia. Credit to the contributor. This is a sagittal T2 weighted image. I'll scroll through these images. Here's L4, here's L5, here's S1. And at the L4-5 level, note some extension of disc material posteriorly. At the L5-S1 level, appreciate extensive disc material extending posteriorly. I don't think we would confuse this for a disc bulge on our sagittal image, but this is likely just a disc bulge, not a disc herniation. As I scroll through, you appreciate in the foraminal zone, here's the vertebral foramina with the dorsal ganglia here. There's not much disc material. As we come to the central part, or the central zone here, extensive disc material displacing the dura and compressing the traversing cauda equina. And as we come out to the other foraminal zone, it's essentially clean. So on the sagittal image, we appreciate there's quite a large disc herniation posterior. On the axial image, we'll scroll from top to bottom. Here's the L4-5 level, small midline protrusion. Here it is here. And then at the L5-S1 level, the extensive, right here, midline protrusion. Note something else that happens in the setting of a high-grade disc herniation. So here is the thecal sac. Let me come up a little bit, you can see it better. Here's the thecal sac here. Now note here, there's all this bright stuff. This is cerebrospinal fluid, or CSF. And all these little dots are nerve roots of the cauda equina. As you come down and you compress the thecal sac, you cause stasis in the cerebrospinal fluid. So you don't get that normal flow pattern that you see on the MR image. In other words, it's not bright because the nerve roots are clumped together and the flow is being obstructed. So that's something common. Now, as we come down more, it reconstitutes. You can see that fluid again. So that compression of the fluid-filled sac is another clue. You're looking at a pretty high-grade compressive lesion here. So this is essentially a central disc protrusion. It's a protrusion because the base is wider than the length here. And it's high grade in the central zone with severe stenosis of both the traversing right and left S1 nerve roots. Here are the exiting L5 nerve roots here and here, by the way. So L5 nerve roots, traversing sacral nerve roots here. High grade compression. Here's a case of disc extrusion from Radiopedia. Here's L4, here's L5, and here's S1 for reference. We'll scroll through the sagittal images. This is an incidental perineural cyst or a Tarlov cyst. And as you scroll through, you can appreciate there's a large compressive mass. This could easily be mistaken for a tumor in the extradural space, but this is just a large extruded disc fragment. If we go to the axial image, we'll come up to L4 right here. Now we'll scroll down to L4-5 right here. Large extruded disc fragment. And I don't see much connection, probably right here, but I'd raise some concern for sequestration in this situation as well. Notice that compared to the last case, this disc material here is a bit brighter. Some think that's a function of hemorrhage, suggesting more an acute phenomena to the disc herniation. So keep that in mind. You might see different colors or different brightness level, rather, to your disc herniations. Some think perhaps hemorrhage is playing a role, bleeding. Others think it's just more nuclear material versus not. So a little bit of a debate as to why we see some different appearances to the disc material here, but nonetheless we do in our disc herniations. This is a large disc extrusion. This lecture has emphasized mostly MR imaging of disc pathology, but I do want to say CT is pretty good for evaluating disc pathology. It's not as good as MRI, but it's pretty good if your patients can't get an MRI for some reason, say they have claustrophobia, or they have a non-compatible pacemaker, or aneurysm clip, or some other reason, or if there's metal artifact that you have to work around. CT can be really helpful, and one of the main reasons is because of the contrast between fat density, which is dark black, and then soft tissue density. Because of the epidural fat, we get a nice interface between disc material, epidural fat, and the thecal sac. Now, where we really lose our resolution is the neural anatomy itself. I can't see the nerve root anatomy or the cauda equina anatomy nearly as well as I can on MR imaging. But as this case shows, you can see nicely disc protrusion, central disc protrusion, without nerve root compression. These are the traversing nerve roots here and here, but with nerve root contact. So disc protrusion without compression, but with contact, and with some effacement of the thecal sac. So this is a clear diagnosis at CT, and the sensitivity and specificities range 80 to 90s here for disc herniation. So CT is pretty good. You do not need a CT myelogram for most of your spine questions. You can get by with non-contrast CT. It's actually pretty good for disc pathology. MR, of course, is preferred because you get better looks at the bone marrow, better looks at the nerves, etc. But if you cannot get MRI, don't be shy to get a CT exam. You'll get a lot of your disc questions answered on your patients. Here is a case I wanted to share from Radiopedia. And we've been talking about the intervertebral disc, so I wanted to make mention of this technology, discography. This is oftentimes termed a provocation discogram. And what it is, it's technology whereby, usually under fluoroscopic guidance, contrast material is injected into the disc. Now, this used to be used to diagnose disc herniation. So, radiologists would assess patterns of contrast extravasation. It's no longer used for that so much as it is used for symptom provocation. This is in the realm of, putative diagnoses of quote unquote discogenic pain and really surgical planning. It's not uncommon to have multiple levels of degenerative discs on MRI, for example, which one may be a dominant pain generator, if any. So just so you're aware, it's nothing I'm familiar with personally, but it's prevalent in the pain medicine world. Provocation discography. Here's just a discogram for reference here. Injection of dye into the intervertebral disc. Now, patients will be awake during the procedure and they're going to give real-time feedback. And it's not looking for pain reduction. In fact, you're looking for pain amplification or reproduction